I was gonna, sometimes it lets me highlight you, but I think I'm just gonna have to pin you. There we go. So you're a little bit bigger. Oh, I think you're on mute.
Yeah, if
Yep.
you can give me co-host privileges, I can see if I can spotlight myself.
Yeah, that's I normally, and I don't know if it was because, it might be because I wasn't on video. Let me see. If I put myself on video, then I can highlight you. Oh, my computer's also being slow, so it could just be me. Okay, now let's see if it lets me do it. Oh, well, I'll play. I've got you pinned, so that's at least good. I will gonna let everyone in and get started here. That way you have your full time.
Mhm.
And I'll push record first. There we go. It's like my computer's moving in slow motion.
Oh,
Yeah. Good thing you're co-host, so. Good afternoon, everyone. Thank you for joining today. I'm Kristen Owens, the Director of CLE for the ISBA. We're so glad you're here. Please place any questions that you may have in the chat box, and Dr. Gleb will get to those as time allows. I'll also put the CLE form and the code word in the chat box, so towards the end of the presentation, so you'll have that. And it is now my pleasure to introduce Dr. Gleb, also called the Office Whisperer by the New York Times. He helps tech-forward leaders replace overpriced vendors with staff-built AI solutions and also serves as the CEO for disaster avoidance experts. He has authored 7 books in total and has an upcoming book with Georgetown University Press called The Psychology of Generative AI Adoption. His cutting edge thought leadership has been featured in over 650 articles, 550 interviews, and now this is our second ISBA CLE webinar with him. So thank you for that. He has over 20 years of expertise in consulting, coaching, speaking, and training for innovative startups, major nonprofits, and Fortune 500 companies. His expertise also comes from his research and teaching background as a behavioral scientist studying behavioral economics and cognitive neuroscience of future-proofing strategic decision making and planning and cognitive bias risk management strategy in business and other contexts, which I know is why you are all here today. So, with all of that, thank you, Dr. Gleb, and I'll turn it over to you.
thank you very much for that kind introduction. I appreciate it, Kristen. Welcome, everyone. So, I'll take care of a couple of logistics first. You should be able to see me. Now, what you'll want to do is pin my view. So click on what you're seeing right now with me on the screen and click on pin. So that's the first step. And then click on view on the top right to make it speaker view and full screen. That way you'll be able to see my slides, which will be right next to me. So not using something traditional like PowerPoint, using a much more advanced technique called Prezi Video, which allows you to see my slides right next to me. So much more engaging, and folks appreciate it quite a bit more. All right. So that's the logistics for seeing me. Now, in terms of getting the resources from this presentation, what you'll want to do is go to the link under my name. Be able to see it tinyurl.com/DAEEVENT. If you're watching the presentation right now, or if you're watching the recording, I'm going to also put in the chat for those who are watching the presentation right now, tinyurl.com/DAEEVENT, tinyurl.com/DAE event to get the book and the other resources from this presentation, like expert witness reports on the science of justifying non-economic damages, so that you are going to be able to have all the resources that you'll need from this presentation. Now, I'm not trying to sell my book. I'll just send it to you pro bono. So just go to tinyurl.com/DAEEVENT for that. Okay, so that takes care of the logistics. Now, let's get on to the meat of the presentation. Justifying non-economic damages, emotional distress, and invisible pain compensation. That's what we want to talk about. That's what we'll spend the next already 85 minutes on. So let's talk about the topics that we'll be covering so that you know what to anticipate. And again, as for another logistics thing, as Kristen mentioned, if you have any questions, just pop them into the chat. We don't have a huge group today, so I'll probably be able to get to your questions. Happy to answer your questions. Just pop them into the chat. So let's talk about the key topics that I'll be covering. One is understanding invisible pain and emotional distress, what that is about, what these concepts are, all the challenges involved in them. Then challenges in subjective evaluation of emotional distress, invisible pain. Then introduction to the QALY metric in legal evaluations. So this is the metric that research has shown is highly useful for actually quantifying invisible pain and emotional distress. So if you are a personal injury attorney, this is going to be very useful for you because lots of folks in personal injury have difficulty accurately quantifying emotional distress, invisible pain, chronic pain, various forms of disability, traumatic brain injury to juries. And so this is what you want to be able to quantify effectively. Okay. Then next, we'll talk about some real world examples where I'll bring up some examples. I'll be doing a lot of sharing of expert witness reports and some examples for our discussion. Then strategies for presenting QALY in court. How can you effectively present QALY in court to make your case? So that's going to be the shape of the presentation. That's what you can anticipate. All right. First, understanding non-economic damages. First, we'll talk about the concepts, the theory, and then we'll spend a bunch of time on practical real-world examples. So let's talk about the theory, understanding these non-economic damages. Emotional distress, emotional harm, intense sadness, grief, anger, anxiety, panic attacks. These are the kinds of emotional responses that your clients can come to you with. Or if you are a defense attorney, these are the kinds of things that you'll be defending your clients from. So I serve as an expert witness on this topic, about 80% of my cases are for plaintiffs and about 20% are for defense. So I'm quite familiar with both sides of the case, and I'll give you some examples from both sides of the case. Then cognitive. Cognitive would be things like negative thoughts, ruminations, difficulty concentrating. So those would be cognitive aspects of invisible suffering, all this negativity, all these problems that people are experiencing. Physical components. So you have things like headaches, muscle tension, sleep disturbance, fatigue, GI issues, hair loss, chronic pain. These are all things, well, hair loss can be visible, but the rest of the stuff is not going to be easily visible, and juries will have a lot of trouble with evaluating and quantifying these. And so this is what we want to discuss and how to help juries quantify this effectively. Okay, what about impact on life? So this is part of the quantification. For personal life, all of these problems that we went over before strain relationships, cause a lot of strain to people's relationships. They result in social withdrawal. In professional life, they result in worse job performance, more absenteeism, and so on. Overall quality of life is reduced pleasure and satisfaction, and the risk of major psychiatric conditions like major depressive disorder or PTSD. So that's the first part. If you have any questions on this overall overarching impacts, please pop them into the chat. All right. And again, I'll be happy to get to them throughout the presentation. Let's talk about some of the issues with traditional subjective evaluation methods of emotional distress and chronic pain and so on, non-economic damages, in other words. There's a lack of standardization. So there's a lack of things that are appropriate. You'll have juries not sure whether to give a $10,000 reward award or a $10 million award. There's a lack of standardization on quantification. There's a lack of standardization on evaluation. There's no clear scientific basis that lawyers bring to the table. They bring to the table stories. They bring to the table depictions, not real quantification in a scientific way. There's inconsistent criteria for assessing distress, and so you can argue about what are the criteria that you use for assessing distress. Variability in tools and scales used. So again, that's a big problem. Dependent on rhetorical skills. So you're basically relying on how persuasive you are. And of course, you might be very persuasive, but the defense lawyer might be very persuasive, or if you are the defense lawyer, the plaintiff's lawyer might be very persuasive as well. So there's a dependency on rhetorical skills to convince the judge or the jury, most often the jury, of course, of whether somebody actually has this invisible pain, emotional distress, and how bad it is, and how much compensation they deserve. And this shows the need for more objective and reliable methods, which is what the nature of the quality methodology that we'll talk about in a bit is like. Now, another series of challenges is variability in individual experiences, so personal differences. People have diverse emotional responses to similar events. Someone who's close to you dying might, for example, might lead to deep sadness for some people or transitory sadness for others. Not blaming someone for either one of those is just the fact of the matter, how people respond to things. There's an influence of personal history and context on people's lives. There's cultural factors. So different cultures express emotional distress in different ways. There are different coping mechanisms and support systems. This variability shows the need for a more scientific, standardized approach, where we can take population level studies and make average evaluations across population level studies to present a more objective, quantified evidence base to the trier of fact. So that's why we need objective measures, ones that are more scientific, incorporating quantitative metrics, ensuring reliability and standardization across cases. The legal implications of this methodology is it will help meet this Daubert standard in terms of being highly qualified by peer review, extensive research, wide acceptance in the scientific community, providing enhanced credibility in the courtroom. And I've had cases in a number of states. I've had cases in Ohio. I've had cases in California. I've had cases in Texas. Oh, I've had cases where I was in recently Pennsylvania, Maine, Maryland. So in a number of jurisdictions. I'm actually talking to someone right now about a potential case in Indiana. So there's many jurisdictions that are quite comfortable with this methodology. Yes, Kansas, that are quite comfortable with this methodology. Okay, so let's talk about the methodology itself, the QALY metric. What's that about? QALY refers to the quality adjusted life years. Quality adjusted life year. So that's what QALY stands for. Quality adjusted life year, combining quantity and quality of life. So what you're looking at is how good is someone's life and how long somebody lived. That's what QALY is about. So quantification, that's what it's about. Quantifying the quantity and quality of life. Okay, so let's talk about how do you calculate quality. One QALY is 1 year of life in perfect health for somebody who is in a specific demographic, in a specific category. So obviously, someone who is going to be 20 is going to have better health than someone who's 40, but it's going to be adjusted for people who are 40 versus people who are 20. And same thing for various other demographics. So 1 year of life in perfect health for somebody who is in a specific demographic. Half of a QALY is 1 year of life at 50% quality. And so that is the evaluation, like how do you measure quality of life for half compared to one? We'll talk about some examples, but that is just the mathematical difference. And so using this mathematical difference, you can get at what is actually happening and quantify it to the triad effect. What are the components of quality? How does it break down? It's length of life measured in years lived. So what's the expectation for how long somebody will live? Longevity, thus the length of life, and the quality of life. What's the health-related quality of life measure? So things like physical, mental, social well-being, all aspects of quality of life. And so there is where we get at the invisible pain, traumatic brain injury, PTSD, depression, anxiety, these sorts of things. And so that is those factors influencing quality of life, physical, mental, and social well-being. Formula for quality combines both. So quality is the length of life times the quality of life. That means for the average American, the average quality is going to be around 80 over their whole life. So you'll have the expected life for somebody that they will be, the average person will have around 80 qualities. So live around 80 years, a little bit less for men, a little bit more for women, that they'll live in health that's appropriate for their age group and demographic for that period. And if there's somebody suffering an injury that caused them emotional distress, that caused them chronic pain, and so on, that takes down their quality of life. And so if it's a permanent injury, then it's going to be however many years they have left to live, that's permanently taken down. So you evaluate what the consequences for their loss of quality over that period. Let's talk about the background of quality. Where did it come from? It was developed in the 1960s by health economists. Health economists, public health experts, those are the kinds of folks who developed this quality of life measure. Its first use was to assess the value of medical interventions. So if you're thinking of how much is it worth to assess, to have a medical intervention, like let's say if you're thinking of doing a surgery or providing certain medications, how many people will it save? How many life years will it save? How many people will it save is a much cruder measure than how many life years per person will it save. So that's the quality of life metric. How many lives will it save, and what quality of life will somebody have, and how much will certain medications, certain surgeries, whatever other medical interventions, vaccines, stuff like that, will improve people's quality of life. It evolved over time to be adopted by public health and health economists widely. It's used right now since the 1960s. It's widely used for policymaking and resource allocation by the US government, by all sorts of governments around the world. So standard quality evaluation is $165,000 per quality in the US in 1965. I'm sorry, in 2025. So let me see if I can bring this up quickly. Uh, Demonstration. Yeah. So you should be able to see my screen. So this is, as an example, just quickly brought up the US Department of Transportation, and you can bring up other government agencies. So looking at statistical life and economic analysis, the base year is 13.7 for 2024. And there's a little bit of, so that's what you can see. That's the value of a life. That's how the government currently values life in inflation-adjusted life years. So each human life is valued at $13.7 million. And how do you get 165,000? Well, okay. So was a little bit out. This was the, I need to update this PowerPoint a little bit, this slides a little bit. So the value is not 13,200,000, it's 13,700,000. So I need to update this, but it's basically, you can see the average life expectancy of 80 years. The calculation is that 13,200,000 divided by 80 is 165,000 per quality. So it will be a little bit more because it's 13,700,000 divided by 80 years. So it will be something like $167,000 per quality for the current evaluation. So when I would go to court, I would just look up the latest numbers and cite that. And you should do the same. So it will be 167,000 per qual. Let's talk about how you're going to evaluate quality impact of various interventions and various injuries to your clients, or if you are a defense lawyer, then defending from various claims. So let's say quality loss due to depressive symptoms. Let's take a look at that. So there was a study, and I'll send you, again, go to tinyurl go to the link that I gave you earlier, tinyurl.com/GAEEVENT, and it's going to be in the chat. And I'll send you a copy of the slides so that you can take a look at these studies and get all the information from the studies. So this is an example of a study that measures quality of life years associated with depressive symptoms, focusing specifically on US adults aged 65 years and older, applicable to other US adults as well, obviously. So it examined quality loss. The study overview. It analyzed data from the CDC, over 3,006 US adults over 65 years old. The reason it's focusing on people 65 years and old is because of Medicare, which is keeping track of these, but obviously applicable to adults who are younger than that. From 2005 to 2011, it examined the association between quality adjusted life years, and depression, measured via the patient depression questionnaire, which is a highly standardized, widely accepted metric of how you measure depression. So it had certain severity categories, with non-minimal being 0 for 4. Then mild depression is 5 to 9. Moderate depression is 10 to 14. Moderate severe to severe is over 15. What's the study results? Average quality lived from start of study period for each depression severity category. Non-minimal, so from the start of the study period, to when these people died, would be altogether 14 qualities on average. And this is people who are 65 years and older, but it's obviously, again, applicable across that. So 14 qualities, that would be the baseline of what you should expect for people with non-minimal depression, which makes sense if you're looking at people who are 65 years and older, then you should expect them to live something like around an average to 80. And so if you have 65 years and older, some of them who were studied, they were probably 70, 75. So living approximately 14 quality means that they lived in approximately good health until they were in their around 80, early 80s. So this is the expected situation. This is the normal category if they don't have depression. 14 qual. That makes a lot of sense. Totally reasonable. So you have your what's called a sanity check that this makes a lot of sense. Then, if they have mild depression, what happens? They lose a lot of quality. They lose something like 45% of their quality, which you can certainly understand that if you have some depression, mild depression, it's still depression, and people who are depressed will have both worse quality of life and they will die earlier. And so depression has definitely been associated in a lot of studies, and that will be part of the expert witness report that I write, that it's been associated with both loss of length of life and loss of quality of life. Again, remember, quality is both. Now, why does somebody live a shorter period of time if they're depressed? Well, the one of the main reasons is they have less social contacts, and social contacts have been shown to be strongly associated with increased length of life. Social support, very important. And so that's kind of one. And of course, they're also less motivated to take their pills, to do everything else that they need to do to exercise, to eat right. And so those are things that will bring down their longevity. So they will live shorter. But not only will they live shorter, but they will live worse. So that's the quality of life. The quality of life because they will be more depressed and less happy and they will do less enjoyable things. And so that's going to bring down the length of life and the quality of life alike. So we're losing about 45% or so of quality from non-minimal to mild depression. Going to moderate depression, so going to more significant depression, you're losing even more quality. So you're losing something like around another 20-ish% of your quality from going from mild to moderate compared to non-minimal. And then moderate, severe to severe, you're going to lose another 10% or so of your quality. And so you could see that by the time you get from 14 to 3.3, you're losing something like 70-ish% of your quality of life. That means it's a combination of living shorter and living worse. So that's the way that you estimate and evaluate quality using research like this. And there's a lot of research like this out there on people that are associated with specific conditions. So it significant quality loss quantifies, puts a number on emotional distress. So major depressive disorder on average is 8.3%, 8.3 quality, so 65% loss. Major depressive disorder means it's a combination, it's either moderate or moderate severe or severe. So it's kind of the bottom two categories. So that's an average 8.3 fewer quality compared to non-minimal. So it's a 65% loss of quality of life. That's the average between moderate, moderate severe, and severe. And so mild depression, by contrast, is 6.2 fewer quality. So that's a 44% loss that I showed. So that's how much loss you'll have 44%, like I said, 40-ish%, so it's 44% versus 65% if you're going to be in either of the average of the two bottom categories. These patterns are consistent across demographics and comorbidities. So it's not like somebody had diabetes and that's why they had depression. This was controlled for diabetes. It's not like somebody has, I don't know, a certain demographic that you might think that, well, that demographic is more likely to be depressed. No, this is controlling for certain demographics. So this is consistent across demographics and other illnesses. So this is controlled for those. The implications of the study is that every year of major depressive disorder, you have $107,000 loss, quantified loss, a little bit more because we'll use the $167,000. So that's probably about $110,000 loss in current estimates according to US government statistics of how much quality of life is worth. So if some event brings about such a disorder, then the cost of the patient experiencing the disorder should be about $107,000, well, $110,000 per year. So if you have a situation that results in a therapist or psychiatrist diagnosing a patient as a result of an injury, with a major depressive disorder, then you can use these numbers to say that that's the cost of this disorder to the patient on average, and which is the most fair estimate because you can make up stories about anyone anywhere in a specific personal context with a subjective evaluation, but here QALY is much more scientific and objective. In the most objective metric that we can use, it's going to be about $110,000 per year in terms of the cost to the patient from the injury. And then, of course, it's going to be a question of how long depression lasts, and we have plenty of research on how long an average depression lasts. So other studies provide similar assessments of QALY loss for other types of mental distress and physical injuries. So let me cite as an example, I'm just going deep into depression as an example. There was another study of quality adjusted life years in older adults with depressive symptoms and chronic medical disorders, which followed older adults for 4 years, found that depression is one of the worst medical conditions decreasing QALY, just below arthritis and heart disease. So if you think of other impacts, arthritis is terrible. Well, it's the joint pain that's highly debilitating. Heart disease, obviously, the leading killer of people in the US. So depression ranks just below arthritis and heart disease in terms of how bad it is for people. What about this assessment, PHQ-9 quality assessment? I often get from defense lawyers often ask me this question, how do you actually measure QALY? Like, is this a fair estimate? I reply with studies, of course. So there is a research study on estimating QALYs based on PHQ-9 scores, which obtained randomized controlled trials that administered both depression screening tools and the EQ-5D-3L, which is the most common tool used to assess QALY, quality of life years. And so it found that depression screening tools like PHQ-9 accurately correspond to EQ-593L. So we have the widely used, this is the most widely used tool for screening depression, PHQ-9, and the tool that's most highly used for evaluating QALY, EQ-593L, are highly correlated to each other. So we see that higher depression is highly correlated to lower QALY. Validates the use of PHQ-9 in assessing QALYs loss due to depression, and so peer-reviewed research supports QALY analysis of depression. How about QALY in legal cases? It provides objective evidence for legal compensation. So, by the way, if you have any questions on this quantification, I'm happy to take these questions. Pop them into the chat so we can chat about them. So, the use of QALY in legal cases. It provides objective evidence for legal compensation, rather than the type of subjective evidence that is very commonly used. It demonstrates the clinical importance and statistical significance of QALY. It helps lawyers use QALY to support claims for physical injury damages that are not so visible. So if you're talking about traumatic brain injury or chronic pain that jurors can't see, that's perfect use case for QALY. Emotional distress damages, whether it's PTSD, anxiety, depression, or so on. It helps you provide an objective measure of mental and emotional harm to people, as I saw. So apply the findings to enhance case credibility and defensibility alike. That's where the usefulness of QALY is for you. And it's great for the Daubert standard. So Daubert standard is a legal precedent for expert witness testimony used by judges to assess reliability, relevance of expert witness testimony, of course. So the criteria is that it's testable. The theory can be tested, and we have extensive peer-reviewed evidence of its testability. Peer review, it has been peer-reviewed, widely accepted in the scientific community. Error rates, known or potential error rates, absolutely, we have that evidence quite widely available. Existing standards for technique, absolutely. PHQ-9, EQ-593L are very, very widely used. So we know that those are highly standardized instruments. General acceptance in academic or other expert community, yes. In academic community, public health economists, widely accepted by public health experts, widely accepted in government circles. So we saw the evaluation of the statistical quality statistical life from the Transportation Administration, right? So quality is great for that. So it's testable metric in health economics. It's extensively reviewed in scientific literature, standardized methods that minimize error rates, established quality lines for quality calculation, and widely accepted. Public health, health economics, government officials, and so on. So thinking about expert witness testimony, it provides quantifiable health outcomes with a clear framework for emotional distress and physical damage. Provides a standardized approach to ensure consistency. It shows rigorous scientific methods and simplifies complex health evaluations to convey a consistent and clear message to the jury. Okay, let's talk about some case studies. By the way, if you want to ask me, like I said, happy to answer any questions, but right now I'll get to some case studies as an example. All right, so let's talk about one specific example of application of QALY. Walter Down versus Downs Racing in Mohegan Commercial Ventures. This is a case in Pennsylvania. So what's the situation here? So Walter Dunn, Mr. Dunn, experienced a traumatic incident at Mohegan's Pennsylvania spa. He was in the in the steam room for 15 minutes. He began feeling lightheaded, tried to exit, but discovered the door was locked. He received no prior instruction from the spa staff regarding the operation of the steam room, safety procedures, whatever. He became increasingly distressed. Oh, he lost consciousness, collapsed, injured his head and body. Where he was treated for heat exhaustion, mild head trauma. And so the actual lasting physical injuries, there wasn't really much lasting physical damage. The problem for Mr. Dunn was his pre-existing psychological conditions, PTSD, depression, and anxiety. So he had some well-treated PTSD, depression, anxiety prior to this, where to the extent that it was it was basically very mild by that time, highly controlled. And this incident seriously exacerbated his PTSD, his depression, his anxiety. So the analysis indicates that his emotional and physical reactions during the sauna were significantly influenced by pre-existing psychological conditions. He was trapped, he couldn't control the environment, and he's a former veteran, so that's kind of where controlling the environment is really important to him, triggering intense panic and feelings of helplessness. There was no clear instructions, heightened his fear, with psychological theories regarding trauma response. The inability to manage the sauna's heat or secure timely escape significantly compounded his distress. So, what about metrics? So clinical assessments using standardized diagnostic tools such as PTSD checklist, general anxiety disorder, and patient health questionnaire demonstrate substantial distress and functional impairment. All of these are the most standardized checklists that you use to evaluate physical distress, emotional distress. PTSD was evaluated using the PTSD checklist, PCL5, generalized anxiety disorder, that's GAD-7, patient health questionnaire, PHQ-9. Demonstrate substantial distress and functional impairment. So recurring nightmares, sleep disturbances, hypervigilance, paranoia, difficulty concentrating, significantly heightened anxiety levels. So his emotional state post-incident really deteriorated. He had to resume intensive therapy and group counseling, similar to the intensity experienced many years ago. His daily functionality, social interactions, quality of life dramatically declined. The incident set him back for many years regarding sleep patterns, hypervigilance, defensive driving, and intense anxiety. So here talk about QALY, and here's expert qualifications, whatever. I'm not going to go through all the cases that I did. Let's see, documents consulted. Okay, so prior to the event, he had achieved considerable progress in managing his diagnosis of mental health symptoms, including PTSD, depression. He achieved considerable progress in his self-management, indicating relatively stable and improved life. As a result of the event, he had significant expressed feeling more upset about it than initially realized, persistent anxiety and depressive symptoms, which is pretty typical that after the initial event, things go downhill essentially. People deteriorate and have worse and worse symptoms over time. So, PTSD symptoms were pretty bad, quantified by the PCL diagnostic assessment. He exhibited severe distress, intrusive and repeated memories of the traumatic event, recurrent disturbing dreams, physical reactivity to reminders of the trauma, avoidance behavior. He was reluctant to return to environments similar to the incident setting, gyms, facilities featuring steam rooms, hypervigilance, inhibiting his social interactions, leading to more isolation, emotional detachment. Anxiety and depression had a marked increase in both conditions. He reported experiencing anxiety nearly every day, as opposed to quite rarely prior to this. Depressive symptoms included diminished interest in previously enjoyable activities, chronic fatigue, appetite disturbance, leading to significant weight gain, low self-esteem, difficulty in concentration, and a persistent sense of hopelessness. He articulated that the traumatic incident set back his psychological state for many years. Frequent nightmares associated with past military traumas, more hypervigilance and defensive behavior, increased defensive driving, and so on. So those are some examples of how he suffered. So this is just describing the quality methodology. I'm not going to go through it in high detail. So this was just talking about the methodology. Just, again, quantifications of methodology. And this is like going in depth into his situation. Then this is going through each of the checklists and experiencing what the scores are. He reported nearly every day experiencing little interest or pleasure in activities, 10-pound weight gain, trouble concentrating. And so here you cite the scores, look at, so again, you can get this questionnaire, get a psychologist to do this questionnaire and evaluate what the scores are and talk about the scores. Report extreme physical reactions, endorsed quite a bit for intrusive thoughts. His overall PHQ-9 score of 22 falls into the severe depression range. So we talked about the moderate, mild, severe. So his falls into the severe depression range. His PTSD checklist. So extreme psychological reactions, hypervigilance, and so on. His cumulative PTSD score was 67 out of 80, well above the clinical threshold, which is 33. And he had high anxiety disorder, a maximum of 3 for each item. So severe anxiety. How do you quantify this? Let's talk about these details. Research on PTSD, so we talked about results in average loss of 34% of quality of life. So that is just when you look at the research, and that's the study cited, shows that an average loss of 34% of quality of life. So not as bad as depression, but pretty bad. Individuals who had mild depression and developed moderate severe depression, which is the case for Mr. Dunn, lose 42% of their quality of life. And so we know that he lost 34% of his quality of life due to depression, 42% of quality of life, 34% due to PTSD, 42% due to his depression moving from mild to moderate, severe, severe. So how do you actually math this? So you take a look at what the losses are for each of them, and you multiply them out, and you look at what the total loss is per month. And then we could evaluate how long we expect his symptoms to last. His condition, despite substantial efforts, hasn't improved in a significant fashion over the 19 months since the incident. And so the problem is the underlying trigger is still there, given the case is not resolved. Once the case is resolved, he can begin to recover. Based on the past history of recovery, you can say that he'll recover within 4 to 5 years, so an average of 4.5 years or 54 months. So altogether, with 19 months of symptoms so far, and presuming an average of 9 months until a trial, another 42 months, we have a total of 82 months multiplied by 8,487 is the total ask is for nearly $700,000 in damages. And so that's how you quantify QALY in this specific case with Mr. Dunn. Let's take another example. Okay, so let's talk about Mr. Nolasco. So here so we talked about a situation of someone who, as a result of personal injury to himself, experienced these emotional damages and so on. So pretty bad stuff. Let's talk about a different situation. I want to talk right now about someone who experienced physical damage that's not very visible and how you can use QALY to quantify that physical damage. So Mr. Nolasco, 34-year-old logistics specialist, suffered severe polytrauma in a motorcycle collision, including bilateral wrist fractures that required internal fixation, clavicle fracture, multiple right side rib fractures, pneumothorax treated with a chest tube. So he didn't have permanent, visible physical pain like a broken leg that you can see that he will never walk again in his life, but he had not very visible symptoms with documented persistent pain, vertigo, sleep disturbance, potential PTSD. By the time I got the report, we didn't, by the time I needed to submit the report because of the timeline of the situation, we didn't get a therapist report, so the PTSD was left as a potential case and weight gain. And so there was a calculation of a disability profile of a -5, pain disability questionnaire 93, ACEs 55, which all signal moderate to severe functional loss and pain interference. And there was limited recovery experienced over the 6 months since the initial injury, indicated Mr. Nolasco, who again is 34, faces significant lifelong loss of health with only limited recovery potential, substantial ongoing medical expenses, and profound quality of life reductions attributable to the crash. So that's the context. We're going to talk about QALY. So he is projected to live about 44.2 additional years. So that's the basis for the QALY calculations. Let's see. Okay, so here's just the nature of the case. His motorcycle was struck by a vehicle, causing him to be thrown from a bike, losing consciousness. All right. Medical findings and current clinical status. Chronic pain. Pain disability questionnaire score of 93. That's pretty high and again, this is a standard metric of pain. It places Mr. Nolasco in the severe disability category, signifying pervasive pain that interferes with self-care, work, and recreation. Clinical notes. So I get what happens for context. I got a report from the medical doctor that evaluated all these things, and then I wrote the expert witness report quantifying the pain and suffering. And we didn't have the therapist report in a timely manner, so I couldn't quantify PTSD. So just, as you can understand the reality of cases, sometimes you don't have all the information. So I left that open, saying that if he has PTSD, here would be additional damages. If he doesn't have PTSD, the damages are limited to X amount. So clinical notes describe constant bilateral wrist pain, heightened left hand exacerbated by cold exposure, repetitive motion. So this is the current level of pain 6 months after the incident. Future recovery is expected to be slight. So we have, when you look at the research on how long, what happens if someone didn't really recover with 6 months after the incident, you can expect that this situation will keep happening throughout their life. Orthopedic. Musculoskeletal trauma, bilateral comminuted displaced radius fractures that were standardized by open reduction, internal fixation on October 24th. So he has healing alignments, yet persistent articular irregularity in both ribs. Left thumb exposes marked motion loss in multiple joints. So there's interflexation is limited to 35 degrees, 28 degrees, and so on. So these are just kind of some numbers to give an understanding of the limitations. Grid strength is diminished by literally, pronouncedly in the left. He calculated an upper extremity impairment values that lead to a whole person impairment of 17%. And this is just impairment of motion separately from the pain. Disability is of arm, shoulder, and head, dash score of 56, which indicates moderate disability. American Shoulder and Elbow Surgeon, AC score of 58, 5% moderate functional loss in the shoulder complex. Again, further recovery is likely to be limited. So these are consistent with a whole person impairment of 17%. So we have, in addition to chronic pain, we have impairment of by 17% of his ability to move his hands. Well, his ability to move his hands is impaired quite a bit more, but on the whole person, you consider his ability to move his feet, which has not been really impaired, but his hands are the issue. So whole person impairment of 17%. So compared to a regular person, he's 83% capable for his age group and demographic, and expected to keep that throughout the rest of his 44.2 years of life. Now, he also has dizziness. Evaluation of is a problem of dizziness is obviously quite serious issue. If you haven't experienced it, it can cause a lot of suffering for people. Now, there are repositioning maneuvers that produce partial but incomplete symptom relief. And so this still occur with rapid positional changes, limiting confidence and mobility, increasing fall risk, reducing likelihood of further recovery, but he did recover somewhat. So unlike these chronic pain and orthopedic injuries, he had some recovery from his vertigo. So he meets ICD-10 criterion for parasomnia-related sleep disturbance, frequent startling awakenings. This exacerbates daytime fatigue and pain sensitivity. And again, 6 months afterward, he hasn't improved, so that's serious. So he's currently undergoing psychiatric analysis to confirm or rule out the diagnosis. So we're not just like pulling PTSD out of thin air. The medical doctor indicated that Mr. Nolasco may suffer from PTSD, but he doesn't have the expertise to actually diagnose PTSD. Okay, functional analysis. Prior to the collision, Mr. Nolasco was a vigorous, self-sufficient 34-year-old who performed his own bathing, obviously, dressing, laundry, routine household chores after full work days. After a full workday, it averaged 12,000 sticks. Remember, logistics specialist in a warehouse. In the immediate aftermath of his bilateral wrist fracture and so on, he required his partner to feed, bathe, and dress him, transforming her from a co-parent to a full-time caregiver. So they had children, and this was a problem. Vertigo forced them to abandon marital bed for the living room couch, where their daughter frequently slept beside him for reinsurance. Medically imposed 10-pound lifting limit prevented him from picking up even his 3-year-old Isabel, his other daughter with special needs, or assisting in the two-person gastrostomy tube changes in which the child's nutrition and safety depend. Only recently has been able to hold her briefly. Grocery, carrying, laundry, transport, and cleaning now fall on his partner. And there's mounting childcare and medical costs. So that's all the problems. His position in inventory management previously required frequent manipulation of parts, and now he has serious caps at lifting 10 pounds, confining him to light duty for at least mid-December 2025, likely later, but this is just kind of the current confinement. He exhausted all paid time off. Their credit score deteriorated, which is a problem, obviously. His income fell by approximately 60%. Before the crash, he had lots of fun with frequent weekend trips. Those outings ceased entirely, and that's a really problem. He can't play video games with his daughter. This was a number of holiday parties that were canceled, so this was pretty problematic. No sex, which is obviously bad for depression, weight gain, and so on. So it converted him from an autonomous provider and engaged father into an individual dependent on his spouse for basic self-care, childcare, and transportation. Lost wages, depleted savings, damaged credit, and so on were pretty serious. So that's kind of the context of the situation. And if you just describe that to the jury is like sympathetic, but how much does it actually cost and how much are they going to give him? Are they going to give him like 50,000? Are they going to give him a million? Like what, maybe more? Like what's the range? What's the jury going to think? It's hard to make this assessment. So let's take a look at QALY and how you use it. Chronic pain. We assume that he entered the collision with no chronic pain. Counterfactual baseline utility is 1 QALY per year. Because of his pain disability, questionnaire places him squarely in the severe or high impact chronic category. This evaluation is over 5 months after the accident. We expect a substantial long-term reduction in health-related QALY just for physical pain. Multiple cohort studies converge on mean utilities between 0.4 and 0.5 for adults reporting severe daily pain. So that, for example, Torrance et al. Found an average EQ59 index, which we talked about before. That's the QALY. In respondents with chronic severe pain was lower by 0.57 QALYs compared to pain-free controls, suggesting a decrease of 57% from baseline. There was even another researcher found a loss of 64%. But I'm going to say that just for the sake of being conservative, not making a higher claim than necessary, using the more conservative Torrance estimate, that for the 6 months from the injury until the PDS assessment, Mr. Nolasco lost 57% of his quality of life due to pain alone. So over 6 months, 57% of his quality of life. What can we anticipate for Mr. Nolasco going forward? Research shows that chronic pain is difficult to cure once it lasts for 6 months. So deploying standards of care best practices such as multimodal rehabilitation programs have shown some promise. One study showed that this intervention significantly improved QALY for those with chronic pain, going from 0.34 QALY to 0.44 QALY at 1 year follow-up. So this improvement over 1 year suggests that if he gets high quality care, his pain may decrease from him losing 57% of his QALY to 40% of his QALY due to chronic pain over the next year. Now, about half of those with chronic pain still report chronic pain over the next 11 years. After 11 years, any recovery is unlikely. So we should expect that Mr. Nolasco has a 50% chance of recovering over the remaining years of his life. So on average, we should expect that he will lose 23.5% of his health due to chronic pain in this period, remaining period of 43.2 years of his life. So that's 40%, 47% times 50%. Good. If you have any questions about the math here, please go ahead and ask me. So again, he has a 50% chance, that's 50%, of recovering over the remaining years of his life, 43.2 years. So he has a 50% chance of going from 47% to zero. That means that the expected loss is 23.5%, so half of 47%. That's the math. Let's talk about the wrist injury. So that's the chronic pain. And then I'll show you later how we add all of this up. But we can see 6 months, another 6 months of 6 months, and then 1 year, and then the rest of his life, 43.2 years. Okay. What about DASH score 55, ACE score 55, 50, DASH score 56, ACE score 55? So moderate functional loss in the shoulder complex, separate from any physical, any chronic pain. We're just talking about physical impairment. So Rasberg et al. Measured EQ-59 utilities in patients with head and arm injuries climbing from roughly 0.71 at 3 months to 0.75 at 6, and then 0.81 at 12 as their median dash. So they had a median dash went from 30 to 17 to 12. Of course, his dash score significantly higher, meaning worse than study participants, suggesting that time of the evaluation he might have had his quality of life reduced by at least 35% over the 6 months prior to Dr. Reed's examination due to the wrist injury. So over the 6 months prior to the medical examination, 35% of loss of quality of life just due to the wrist injury itself. What about lasting? So the same study suggests that Mr. Nolasco's injuries, which are substantially more severe than a typical study participant who had a DASH score of 30, not 56, that will take, if he recovers at the same rate as the patients in the study, it will take about 9 months for his DASH score to fall from 56 to 30, at which point he would experience a 29% loss of health using these comparatives. Another 3 months, he should fall to 17, where he would experience 25% loss of health. In another 6 months, he should fall to 12, where he would experience a 19% loss of health. At this point, they found that there was a study that found that while all patients treated reported 57% of patients treated reported noted symptoms. So Mr. Nolasco thus belongs in a later category. If his symptoms don't go away after 5 years, we can assume that they would be permanent. So he has a 57% chance of having quality loss of 19% for the remaining 42.8 years of his life, or total expected loss of 11% over the remaining years of his life. So again, just do the math and you do the probabilities and you quantify that out and you look at what's the loss of quality. Vertigo. So the experienced significant vertigo and some repositioning maneuvers have provided partial relief, but he's still having vertigo issues. So there was another study looking at vertigo issues using standard quality measure. So there's an EQ-59 measurement of utility degrees of 36% due to vertigo. So vertigo, where you have severe dizziness when you're getting up, can be pretty debilitating. Another study finds that those with vertigo lose 47% of their quality of life on average. So this was, however, focusing on a population of older adults. So given his age, which is younger, we should use the more conservative number, suggesting that he lost 36% of his quality of life due to untreated vertigo. With treatment, we can anticipate that after 5 sessions, nearly all patients recover much of their previous functionality. So likely over the course of the next 6 months, as he goes to treatments, he'll likely recover full functionality. So we're not expecting this to be a lifelong condition. Over the period of recovery, he's probably going to lose another 18% of his quality of life due to vertigo, kind of half of this, basically like a half-life evaluation. So that's vertigo. Sleep disturbance. He was diagnosed with insomnia disorder, night terror episodes, frequent sleep. There was a study that reported median EQ-59 loss of 0.17 for moderate insomnia and 0.33 for severe insomnia. And there's another study of moderate severe insomnia leading to 0.29 loss of quality of life. Again, using this more conservative estimate from Gu, we can assume that during the first 6 months, he lost at least 17% of his quality of life due to sleep disturbance. Now, another study of long-term cohort studies shows insomnia often becomes chronic. 40% of cases persist at least 5 years. And so similar 40% incidents, this time persisting for at least 20 years, becoming effectively incurable. So we can assume that for 40% of those with insomnia, cases persist throughout their life. So over the remaining 44.2 years of his life, there's a 40% chance that Mr. Nolasco will lose 17% of his quality of life just due to insomnia, which is a total expected loss of health of 7% over that period. And then finally, the suspected PTSD. So we didn't have time to perform this before we needed to submit the expert witness report for the case. And so study on PTSD, you might remember from the previous research, an average loss of 34% of quality of life. Then the recovery rates 20% recovered in the first 3 months, 27% in 6 months, 50% in 24 months, 70% by 10 years. The remainder of 23% is effectively incurable. So we can expect a 54% chance that he will recover anytime from 2 to 10 years and a 46% chance that he will recover, stay with symptoms throughout the rest of his life because he already did not recover because the assessment would be at the 6 month period. So if he's currently diagnosed with a 6 month period, this is where he would be. He would be in either of these two categories. So we can anticipate a 54% chance that he will recover anytime from 2 to 10 years, 46% chance that he will continue with PTSD symptoms throughout the rest of his life. And so that's going to be the math. Okay, quality evaluation. So this is going to be a little bit more complex than Mr. Dunn because there's going to be a number of symptoms that are combining together. This is a polytrauma. This is not simply kind of the simpler situation that Mr. Dunn experienced. This is polytrauma, and it's divided by time periods because we expect different recovery periods over this period of time using this benchmark. First 6 months, October 24 to April 25. During the initial acute and postoperative phase, he experienced at least the combined effects of chronic pain, 43% utility, wrist injury, leaving 65, 44%, 83%. So how do you combine them? You just multiply them by each other. So if you lose 43%, if you lose 43% of your quality of life, that's kind of first, then you have 57% remaining. Then you multiply 57% by, then you're going to lose 65% of 57. So in terms, you go from one QALY, which is 1 year in perfect health, you go to 0.57. That's just due to chronic pain. Then you lose 57, you leave 43%. And so that's going to be 0.43 just due to chronic health. Then the wrist injury, you're going to have 43 left times 0.65 times 0.64 times 0.83. So vertigo, insomnia. And so altogether, the remaining utility, so his quality of life was approximately 15% of that of a fully healthy adult. So that during the first 6 months when he was really badly off, he lost 85% of his quality of life. And so Over 6 months, this equates to a quality loss of 0.43 quality. And so the $70,200 would be what we would ask for the first 6 months. Then, if he suffers from PTSD, that will be an additional loss going from 50% of quality of life to 10%. Over 6 months, that would be another quality loss. And so this would be going from 70,200, would ask for corresponding economic damages of 74,250. So that's the first 6 months of how bad the injuries are. Next, rehabilitation recovery. So chronic pain is expected to average 52% utility loss, leaving 48% utility. Then wrist injury averages 28% loss, vertigo 9% average loss, insomnia with 7% loss. And so again, you multiply all of these out. So you see that during the next year, he would be better. He'll go from losing 85% of his quality of life to losing 71% of his quality of life. And so he has 29% of his quality of life left, and he loses 0.71 quality. So over a year, a loss of 0.71 quality compared to the counterfactual of 1 quality is 116,000. PTSD, if he's determined to do that he would lose another third of his quality of life, and then the request would be for 133,650. Okay, the next 6 months, you just do the same thing. You chronic pain, 23.5% loss, functional improvement averages, that's the wrist, insomnia, 7%, vertigo is assumed result, so no more vertigo. So now, after 18 months, from 18 to 24 months, we're assuming that he's at 55%, 0.5 utility compared to somebody who didn't have this injury. And so that would be a request for 36,700 in terms of loss. And if PTSD, that will be if it's determined to be present, that's 51,150. His remaining lifetime. So persistent decrements are expected from chronic pain, leaving 76.5% utility, wrist injury, leaving 89% utility, and insomnia. So you combine these, and you see that over the rest of his life, he's expected to be just about a third worse than someone who did not have this incident. Someone, his shoes did not have this incident because he has chronic pain, wrist injury, and insomnia. So the corresponding damages would be 2.5 million. If PTSD is present, then over 8 years, it will be 765,000, additional 765,000. If the following 34.7 years, it will be 2,659 million. I'm sorry, 2,659,000. And here is the summary, just for visual clarity. Without PTSD, expected loss would be 16.96, total of 2,797,600. If he has PTSD, that would be a loss of 22.33 qualities. That would be $3,684,450. So that would be how you would calculate chronic, that would be how you would calculate the injury with physical and emotional symptoms, but mostly physical here. So I hope that provides some clarity on the case studies and how you'd actually calculate quality. Let's talk about strategies for presenting quality in court. And again, if you have any questions, as always, just pop them into the chat. You want to start by defining quality and its importance, explain how it combines quality and quantity of life, relate the quality calculations to the specific details of the case, use real-life examples to illustrate points, use charts and graphs to depict quality loss, the visual components of baseline and quality impact. Those I find to be really quite helpful. So whenever I do presentations of these, or I advise lawyers in presentations of these, defining quality, explaining these combinations, relating these calculations that I just went through, use real life examples to illustrate points, and using charts. Juries really like charts. Okay, so if highly, I hope this was valuable for you for understanding mental anguish and emotional distress, challenges in subjective evaluation, introduction of the quality metric with some real world examples and strategies for presenting quality in court. For additional resources, as I mentioned before, go to tinyurl.com/DAEEVENT, tinyurl.com/DAEEVENT for a link to the slides, a copy of my best-selling book, The Blind Spots Between Us: How to Overcome Unconscious Cognitive Bias and Build Better Relationships. And I'll be happy to have a free coaching session with you for integrating these strategies into your work. And I will be happy to take any questions at this stage. You can put it in the chat, or we're a small enough group, you can unmute yourself. Happy to take questions either way. Give you 5 more seconds for any questions. All right, doesn't seem like there are any questions. Great. Okay, then. I hope you've enjoyed this presentation, and I hope that you found it illuminating.
Thank you very much. I did put the CLE form and the code word science in the chat box. So thank you, everyone, and have a great day.
Bye bye, all.